All right, let's get right into it. We're going to break down the clinical utility of continuous glucose monitoring, or CGM, in managing diabetes during pregnancy. We'll look at the latest evidence and, most importantly, what it all means for your clinical practice. So let's first just set the stage here. Hyperglycemia complicates roughly 16% of all pregnancies around the world. Now, this is not some niche problem. It's a massive clinical challenge with really significant risks for both mom and baby, everything from perinatal complications to the long-term health of the child. Okay, so given those risks, the big question for all of us is, how do we best monitor and get glycemic control just right? For years, the standard has been intermittent finger sticks, but technology is now giving us a much, much more detailed picture. And this really gets to the heart of it. Traditional blood glucose monitoring, BGM, it just gives you these little snapshots in time. And while that's useful, it's kind of like trying to understand a movie by looking at a handful of still photos. You just miss all the crucial context, like the asymptomatic nocturnal lows or those big post-meal spikes that are really driving bad outcomes. CGM, on the other hand, well, that gives you the whole movie. So let's start where the evidence is absolutely rock solid. CGM use in our patients with pre-existing type 1 diabetes. This is the population with some of the highest risks, and it's where CGM has truly proven its value. And the cornerstone of all this evidence is the CONCEPT trial. This was a major international randomized controlled trial. It was designed to definitively answer one question: can adding real-time CGM to standard care actually improve outcomes in these very high-risk pregnancies? And the answer from the trial was crystal clear. CGM use led to tangible, clinically significant improvements in key neonatal outcomes. We're talking about fewer large for gestational age, shorter NICU stays, and less dangerous hypoglycemia in newborns. These are the outcomes that really matter to us and to our patients. And the data goes way beyond just that one trial. We see this consistent picture everywhere. The CONCEPT trial showed a solid 7% increase in time in range. Real-world data shows macrosomia rates being cut by more than half. And this is the crucial part. It's not just better medicine, it's smarter medicine. Economic analyses from both the UK and the US show pretty significant cost savings, mostly by cutting down on those expensive NICU admissions. Okay, so the case for type 1 is pretty much a slam dunk. But what about type 2 diabetes and gestational diabetes? The conditions we see far more often in our day-to-day practice. Well, here the data is still emerging, but the signals we're getting are very, very promising. For type 2, the early studies show that CGM is just way better at catching that hidden nocturnal hypoglycemia, and patient acceptance, it's through the roof. For GDM, the Flamingo trial is a really key piece of evidence. It found that women using intermittently scanned CGM had over 5 times lower odds of having a baby with macrosomia. And a meta-analysis backs this up, linking CGM to healthier maternal weight gain and lower birth weights for the infants. Now, beyond just management, the conversation is starting to shift towards a really exciting new frontier. What if we could use CGM as a diagnostic and predictive tool? Could we use it to get ahead of the curve and actually predict who's going to develop GDM? Just look at this timeline. This shows the potential for a major paradigm shift. The GLAM study showed that with CGM, you can actually see distinct glycemic patterns in women who will later get GDM as early as 13 to 14 weeks. Now, compare that to our standard OGTT at 24 to 28 weeks. And this really matters because the TOBGM trial showed that treating GDM earlier significantly reduces perinatal complications. And the predictive power here is just remarkable. A recent study built a model using CGM data from early pregnancy, and it was vastly superior at predicting GDM compared to our traditional risk factor models. An area under the curve of 0.953, that is an incredibly strong predictive signal for any clinician. So this all leads to the really crucial point, right? We have this incredible wealth of data coming in. How do we, as busy clinicians, translate it into actionable decisions that actually help our patients? The single most important metric you need to focus on is time in range, or TIR. This is the whole game. It's not just about the average glucose. It's about the quality and the stability of that control. And for pregnancy with type 1, that consensus target is tight, 63 to 140 milligrams per deciliter. So professional bodies like the American Diabetes Association have given us these really clear targets. The main goal is to spend more than 70% of the day in that target range. And just as important is minimizing time spent in hypoglycemia.
especially severe hypo, below 54 milligrams per deciliter. That should be less than 1% of the time, period. Now look, a 70% target, that can feel pretty daunting, both for us and for our patients. But the data shows that even small, incremental improvements have a massive clinical impact. Just let that sink in for a second. Every 5% increase in time and range, we're talking just 72 more minutes a day in that target zone, is linked to a 20 to 28% reduction in the odds of neonatal complications. That is a hugely powerful and motivating statistic to share with your patients. So how do you actually approach this in a busy clinic? This simple, stepwise framework is incredibly practical. First things first, are they actually wearing the sensor? If wear time is low, the data's useless. Second, and this is critical, safety first. Always address hypoglycemia before anything else. Third, look at the big picture. Review the time in range and time above range. And finally, use the ambulatory glucose profile, the AGP report, to dive deeper and spot those patterns that let you really fine-tune therapy. And all of this brings us to the final and I think most crucial question. The evidence for CGM in pregnancy, especially for type 1, is just overwhelming at this point. And the emerging data for type 2 and GDM is incredibly strong. So the challenge for us in the clinical community and for our health systems is no longer about if this technology is valuable, it's about how. How do we ensure equitable access and finally make CGM the standard of care for every single at-risk pregnancy?